Hi, class. I am going to go ahead and try to do a voiceover on the rest of the neurologic alterations discussion that we had on Tuesday. I believe we started somewhere around. Just want to make sure this is on. We started somewhere around. We stopped, I believe, on slide 40 or 41. So I guess I can just pick up on slide 41 as it relates to head injuries or trauma. So let me go ahead and start sharing. So we're not going to get into the emergency treatment of patients who have head injuries. More specifically, the interprofessional care that involves several disciplines, neurosurgeons, surgeons, or neurologists, nurses, and your PT, your OT, and it's an interprofessional approach to caring for these patients. Now, it is important when someone sustains a head injury that we ensure that there is a patent airway. I mean, that's just a given, ABCs, right? So the initial care after stabilizing the airway will also be to stabilize the cervical spine. Remember, if someone or you suspect someone has a head injury, there is a great likelihood that they might also have a spinal injury as well. So you don't want to just indiscriminately just start moving patients around, but you want to stabilize the cervical spine in order to minimize even more damage from occurring. We also want to administer oxygen via non-rebreather mask. We want to establish a couple of IV, 2 large bore catheters. If you can get a 16 gauge, that would be great. 18 certainly ideally, but even a 20 gauge is the minimum that you should really try to get, because at the very least, if the patient is going to require a blood transfusion, then you want a much larger bore catheters. Otherwise, your smaller catheters, they tend to destroy the red blood cells as they go through the catheters. We also want to start normal saline and lactated ringers. These are your isotonic solutions that are certainly used often in trauma patients, because it's certainly good for the intravascular volume increase in order to have a good blood pressure. We're likely going to intubate if the Glasgow coma scale is less than 8. These patients are likely in a coma at this point. We also want to control for external bleeding with sterile pressure dressings, and also remove patients' clothing, so that you can do a good primary and secondary assessment. Look for those inconspicuous injuries that you may not note to be present otherwise. Oh, I guess I should have presented that. All right, so ongoing monitoring of a patient with a head injury during the emergency phase should include the following as well. We want to maintain patient warmth using warm blankets, of course, if possible, or just using blankets, period, if you don't have warming blankets. Also, we want to warm the patient's IV fluids, and this will help to maintain the patient's temperature. Then there's overhead warming lights that should be employed, warm humidification of oxygen in order to provide warmth for the respiratory system. As far as ongoing monitoring, the patient's vital signs should be assessed. Their level of consciousness, in particular using the Glasgow Coma Scale, O2 saturation, place these patients on a cardiac monitor as well. We want to make sure we're continuously looking at the Glasgow Coma Scale and reporting those numbers, especially when they begin to deteriorate. Also, we're looking at pupil size and reactivity, which is a part of this assessment, and note any changes. And also remember that anisocoria, some patients may have a larger pupil than the other, and hopefully you would be able to get this kind of history, if you will. We also want to assess for rhinorrhea and autourea. Remember the CSF leaking from the nasal cavity as well as the ear, and also assess for scalp wounds. Remember, you don't have the vasoconstrictive blood vessels near the scalp, and so they tend to bleed profusely. So make sure also when you're providing pressure, that the pressure is not too great, because especially if there's a skull bone fragment that is loose, and if you're putting too much pressure on that bone, it could be pressing into cerebral tissue. So be careful about the amount of pressure, just enough pressure to stop the bleeding. We want to anticipate the need for intubation if a gag reflex is impaired or absent, and this will help to protect the patient's airway. Always assume that these patients have a neck injury with a head injury, and stabilize accordingly. And also administer fluids cautiously to prevent not only fluid overload, but you also don't want to cause an increase in the intracranial pressure. And too much fluids can do that. So judicious use of IV fluids is required at this point. And so one question I would have for you is why don't you want to move a patient with suspected head trauma? And I'll go ahead and answer that. I believe I've already answered it, but just something to think about as you care for these patients. I guess I did that already. All right. So principles in caring for patients with head injury include measures to prevent secondary injury by treating cerebral edema, because cerebral edema can lead to even more brain trauma. So we want to take measures to reduce this problem. And also managing increased intracranial pressure is another part of the care process. Timely diagnosis. We don't want to take our time trying to figure out what's going on with these patients. So timely diagnosis and treatment is necessary. Surgery, if necessary. The patient might need a craniectomy or craniotomy or burr hole or some form of a hematoma evacuation. So again, that timely diagnosis might warrant surgery. Now, for the patient with a concussion or contusion, observation and management of increased intracranial pressure are the primary management strategies in this regard. Remember, I told you in the beginning, when we first started out with this discussion, the first thing I started out with is um, is intracranial pressure, because when you think about head injuries or trauma, those are the life-threatening problems that these patients might encounter. All right. So the treatment of skull fractures is usually conservative. It doesn't typically require surgery. Now, for depressed fractures and fractures with loose fragments, in other words, when we talk about depressed fractures, the bone of the skull is depressed and it's fractured and it can push into cerebral tissue, which is not good. A craniotomy is necessary to alleviate the depressed bone and remove the free fragments. If large amounts of bone are destroyed, the bone may be removed, something we call a craniectomy, and a cranioplasty will be needed at a later time. All right. Now, in cases of large acute subdural and epidural hematomas, or those associated with significant neurologic impairment, the blood must be removed through surgical evacuation. It must be evacuated out of that the cranial bulb, that small area. Um, Now, a craniotomy is generally performed to visualize and to allow control of the bleeding blood vessels. A burr hole openings may be used in an extremely emergency situation for more rapid decompression, followed by a craniotomy. In other words, when we say decompression, we're trying to alleviate that pressure that is building within the cranial vault. And so a burr hole might be necessary to alleviate that pressure. Now, a drain may be placed postoperatively for several days to prevent any reaccumulation of blood. All right, and that would also help with the intracranial pressure. Now, in extreme cases where swelling is expected, for example, a DAI or hemorrhage, a craniectomy may be performed where a piece of the skull is removed in order to reduce the pressure inside the cranial vault, is what we're trying to achieve here, thus reducing the risk of herniation. You don't want the brain to herniate. That's when these patients are not likely going to make it. Brain herniation results from increased intracranial pressure, which is why we're trying to alleviate that pressure. And it may be caused by a space occupying lesions. It can be caused by generalized swelling or edema of the brain, increased venous pressure, or obstruction of cerebrospinal flow. So again, this is why alleviating that pressure is paramount, of paramount importance for these patients. I got that word spelled, maybe not. Now, a patient with a head injury always has the potential to develop increased intracranial pressure, and increased intracranial pressure is associated with higher mortality rates and also poorer functional outcomes. So we want to obtain the following health information from the patient. We want to look at the past medical history. For example, the mechanism of action. Was the patient involved in a motor vehicle collision? Was it sports related? Was it an industrial, a work issue? Was the patient assaulted? Or did the patient fall and sustain a head injury? All right. And medications, anticoagulant medication use should also be noted, especially in our elderly population, as you can see here. They could be on an anticoagulant such as Coumadin for, let's say, atrial fibrillation. Also, we want to obtain the following information, important health information related to pertinent functional health problems. There's the health perception and health management. We want to know about use of alcohol and recreational drugs, risk-taking behaviors that all can lead to head trauma. Also, there's the cognitive perceptual. We want to think about inquiring about headaches, mood or behavioral changes, changes in mentation. If the patient is experiencing aphasia, dysphagia, is their judgment impaired? And also, as far as coping, stress tolerance, how are they dealing with fear? Is denial, anger, aggression, depression present in these patients? This is all a part of the subjective data assessment. As far as obtaining objective data, take a look at table 56.5. Make sure I note that as well. Essentially, information on assessing and monitoring the neurologic status, and also determining whether a CSF leak has occurred. And we talked about how to determine that. Possible focused assessment findings include, as far as generally speaking, we want to think about any kind of mental status changes. As far as integumentary, look for lacerations, look for contusions, abrasions, signs of hematoma. Does the patient have battle sign? Is there periorbital edema and ecchymosis? Is otorrhea leakage from the ear present? Does the patient have any exposed brain matter, especially if they've had significant brain trauma? Sorry, folks, I had to blow my nose and I didn't want to gross you out. Again, as far as a possible focus assessment findings, it would include looking at the different systems, be that respiratory, cardiovascular, gastrointestinal, urinary. These are systems that we want to pay attention to these patients. As far as respiratory, rhinorrhea, we want to look for rhinorrhea rather. remember leakage of possible CSF coming from the nose. Does the patient have an impaired gag reflex? And so in these cases, we may have to intubate. Does the patient have an inability to maintain a patent airway? Is there impending brain herniation? And those early signs would be altered or irregular respiratory rate and patterns. Then there's cardiovascular. Again, is impending herniation going to occur with these patients? These patients may develop something a term we called Cushing's triad. Essentially, this is systolic hypertension with a widening pulse pressure. These patients also experience bradycardia with full and bounding pulse, as well as respiratory respirations. Now, when we think about Cushing's triad, it just basically refers to a set of signs that are indicative of increased intracranial pressure or increased pressure in the brain. This Cushing's triad, again, the heart rate is going to be very low and the respirations are going to be irregular. And there is also going to be a widened pulse pressure as well. As far as GI wise, we want to look at vomiting. Is there projectile vomiting? Is the patient incontinent of bowel? Is the patient incontinent of bladder incontinence? And so these are all a part of the objective data assessment. And we also look at the reproductive system, neurologic, musculoskeletal, and also some possible diagnostic findings as we continue to assess these patients. As far as reproductive, some of these patients, when they have these head injuries, they will have uninhibited sexual expressions. A certain part of the brain is impacted. As far as neurologic, there can be altered level of consciousness, seizure activity, pupil dysfunction, and cranial nerve deficits as well. As far as musculoskeletal, we look for motor deficits or impairment, patient's inability to move. There might be significant weakness. The patient may develop a palmar drift. Or paralysis or some form of spasticity, muscular spasticity. They also may have decorticate or decerebrate kind of posturing. And there's some photos online that you can look at. This can really show some pretty significant increased intracranial pressure. There may also be muscular rigidity, increased also tone, flaccidity, as well as ataxia, depending on what part of the brain is impacted. As far as some possible diagnostic findings, we want to perform tests that will provide location and type of hematoma. Is edema present? Skull fracture? And or a foreign body on a CT scan or an MRI can reveal such things. Patient may also have an abnormal EEG, meaning they're more susceptible to seizures. And also look for a positive toxicology screen or alcohol levels, which might have part of that kind of recreational activity that leads to these types of issues or traumas. We also want to look at whether the blood glucose levels are increased or decreased. Remember, the brain does require a certain amount of glucose, and of course, it will be pretty difficult to do a neurological assessment and the patient's blood sugar is, let's say, is very low. Remember, less than 20 blood glucose levels, there can be brain damage. And of course, less than 70, we're talking about confusion. And of course, we want to um, perform those diagnostic tests that tells us about the intracranial pressure um, with these patients as well. I think I've hit this part already. Yeah, I did. As far as musculoskeletal. Um, yeah, I, when someone has a palmar drift, they typically have abnormal function of the cortical spinal tract and the contralateral hemisphere. Um, and also take a look at posturing, in particular the decorticate and decerebrate. This is involuntary flexion or extension of the arms and legs, indicating severe brain injury. Um, and of course, with ataxia, the loss of full control of body movement. Let me actually, since we do have a little time, I might as well go ahead and show you a quick picture. Let's see, yeah. So if you look at the top picture, this is decorticate posturing. Look at the plantar flexion here of the feet. There's extension of the knee, and then there's this flexion and adduction um, of the hands and the arm. All right, and then when you look at the decerebrate posturing, you have you still have plantar flexion and extension, but then you have more flexion. Well, you have flexion here as well. But then there's a pronation. There's abduction, or the extremities being away from the body. So just take a look at what this actually looks like. Can indicate increased intracranial pressure and possibly herniation. I don't know why I said stop here. I was just probably trying to just mark off where I stopped. But moving on. And actually, I talked about that one already as well. I don't know if that's a double. It looks like a double um, information on the slide. So we talked about this already, the objective data and what we're trying to obtain and why. So let's just keep on going. So the overall, let me highlight that. The overall goals are that the patient with a head injury will maintain adequate cerebral oxygenation as well as perfusion. The patient will also remain normal thermic. You remember all those warming techniques that we use to help maintain the patient's temperature. We want to achieve control of pain and discomfort because these things can also lead to increased intracranial pressure. So we want to keep pain and discomfort levels um, where the patient is comfortable. Um, we want to make sure the patient is free from infection, free from infection. Also, adequate nutrition. We want to achieve adequate nutrition for these patients so that they might heal better. And also attain maximum cognitive, motor, and sensory function as well. And of course, maintaining adequate intracranial pressure will certainly achieve that maximum cognitive, motor, and sensory function. And this is why it's so important, of course. Now, health promotion is very important. Is a very important part of our job as clinicians. We do rather a lot of teaching because we want to be proactive, not reactive. We want to make sure that we are teaching these patients about safety, especially during certain seasons, especially when school is out, or around water and such as that. So one of the best ways to prevent head injuries is to prevent car and motorcycle accidents. Um, I don't think I can change that. So the use of helmets, teaching folks to use helmets when they cycle has led to fewer TBIs. And so that should be a part of the teaching. The use of car seat belts and the use of child car seats are also associated with reduced TBI mortality and rates. Be active in campaigns that promote driving safety and speak to driver education classes regarding the dangers of unsafe driving and of driving after drinking alcohol and using drugs. The use of seat belts in cars and the use of helmets for riding on motorcycles are the most effective measures for increasing survival after a crash. Protective helmets should also be worn by lumberjacks, construction workers, athletes who play contact sports, um, miners, horseback riders, bicycle riders, snowboarders, skiers, skydivers. Um, Additionally, individuals who are at risk for falls, such as older adults, should be evaluated for safety in the home, as falls are the second leading cause of head injuries for this population. And so a home health care a referral would be important here. Now, management at the site of injury scene can have a significant impact on the outcome of the head injury patient. The general goal of nursing management of the head injured patient is to maintain cerebral oxygenation, perfusion, and prevent secondary cerebral ischemia. All right. Now, surveillance or monitoring for changes in neurologic status is critically important because the patient's condition may deteriorate pretty rapidly. All right, necessitating emergency surgery. Now, because of the close association between hemodynamic status and cerebral perfusion, be aware of any coexisting injuries or conditions, especially cardiac conditions. We want to perform neurologic assessments at intervals based on the patient's condition. Sometimes it might require more frequent assessment. The Glasgow Coma Scale is useful in assessing the patient's level of consciousness. Indications of a of a deteriorating neurologic state, no matter how subtle those changes might be, such as decreasing level of consciousness or decreasing motor strength, should be reported to the healthcare provider stat. Monitor the patient's condition very closely. Explain the need for frequent neurologic assessments to both the patient and their his or her caregiver. Behavioral manifestations associated with a head injury can result in the patient being frightened, disoriented, and also someone who is combative. They may become combative and resist the help that you're trying to provide for them. Now your approach should be one of calm and also being gentle. A family member may be available to stay with the patient, hopefully, and thus prevent increasing anxiety as well as fear. Now, one of the most important needs for the caregiver and family members in the acute injury phase is information about the patient's diagnosis, the treatment plan, and rationale for the interventions that you'll be performing. And this will help alleviate their anxiety and concerns. We want to also perform neurologic assessments at intervals based on the patient's condition. So make sure you take a look at the Glasgow Coma Scale. It is a useful tool to assess the level of consciousness. Report any indications of deteriorating neurologic state. Again, no matter how subtle those changes might be, make sure you're looking at the level of consciousness or decreasing motor strength to the healthcare provider, and just monitor the patient's condition very closely. As far as the care that we will be providing for these patients, the major focus of nursing care for the brain injured patient relates to increased intracranial pressure. However, there may be problems that require some specific nursing interventions as well. Eye problems may include loss of corneal reflex. There may be periorbital ecchymosis and swelling or edema, as well as diplopia or double vision. Loss of the corneal reflex may necessitate administering lubricating eye drops or taping the eyes shut to prevent corneal abrasions. Now, periorbital ecchymosis and edema will decrease with time. Something you have to really explain to the patient and his or her caregiver. But cold compresses and then later warm compresses can provide some comfort and also hasten the healing process. Diplopia or double vision can be relieved by use of an eye patch, alternating for so many hours each eye. That can alleviate the double vision that these patients may experience. And these patients should also be referred to an ophthalmologist for further evaluation. Now, hyperthermia may occur from injury to or inflammation of the hypothalamus. Elevations in body temperature can result also in increased cerebral blood flow, which will in turn increase the intracranial pressure. It will essentially increases the volume that is returning to the brain. And so one of the reasons why we want to maintain or avoid the hyperthermia. Increased metabolism secondary to the high temperature increases metabolic waste as well, which in turn produces further cerebral vasodilation. Remember that vasodilation is what causes more blood flow to the brain. And remember those three components of intracranial pressure: the brain tissue, blood flow, as well as cerebrospinal fluid. And so cerebral vasodilation would not be a good step in a good step in the right direction, if you will. We want to avoid hyperthermia with a goal of keeping the temperature 36 to 37 degrees Celsius as a standard of care. We want to use interventions to reduce temperature in conjunction with sedation as necessary in order to prevent shivering. Shivering can also lead to increased intracranial pressure. And so these are things that we want to alleviate. Right. Now, if cerebrospinal fluid, rhinorrhea or autourea occurs, inform the healthcare provider immediately. Remember, this can lead to a meningitis, which can also lead to increased intracranial pressure. Now, the head of bed may be raised to decrease the CSF pressure so that a tear, if there's a tear, can seal. A loose collection pad may be placed under the nose and or over the ear. Now, do not place a dressing inside of the nasal or ear cavities. And also, we want to document the amount of drainage each shift. And this padding, of course, collection padding, can catch the CSF if it is present. We also want to instruct patients to not sneeze or blow the nose. Actually, I want to put a little emphasis on that. Yeah, so this is also a part of the patient teaching as well. We do not insert nasogastric tubes. They can worsen the basilar fractures. And do not perform nasotracheal suctioning on these patients because of the high risk of meningitis as well. Now, nursing measures specific to the care of the immobilized patient, such as those related to bladder and bowel function, skin care, infection, are also indicated as we care for these patients. Nausea, vomiting may be a problem and can be alleviated by antiemetics. Headaches can usually be controlled with acetaminophen or small doses of codeine. If the patient's condition deteriorates, intracranial surgery might be required. A burr hole opening or craniotomy may also be indicated, depending on the underlying injury that is causing the problems. The emergency nature of the surgery may hasten the usual pre-op preparation, and so we may have to kind of go through that pre-op preparation very quickly in order to get the patient to surgery. The neurosurgeon is also consulted to determine the specific pre-op nursing measures that are needed. So make sure you get a hold of the surgeon, the neurosurgeon, so they can provide more specific information that can allow you to hasten that pre-op period. Now, the patient is often unconscious before surgery, making it necessary for a family member to sign the consent form for surgery. This is a difficult and frightening time for the patient's caregiver and family, and requires sensitive nursing management and support. The suddenness of the situation makes it especially difficult for the family to cope. So use the interprofessional team, including social workers, to assist the patient and family throughout the hospitalization and recovery time. As you know, they're very good at at this. Now, once the condition has stabilized, the patient is usually transferred for acute rehabilitation management. There may be chronic problems related to motor and sensory deficits, problems related to communication, memory, and as well as intellectual or cognitive functioning. Many of the principles of nursing management of the patient with a stroke are appropriate for these patients. Essentially, the same way you would handle a CVA would be apropos here for these patients. Now, conditions that may require nursing and interprofessional management include poor nutritional status, bowel and bladder management, spasticity. There's certain medications that might be provided for spasticity, and also dysphagia, and certainly making sure the patient does not aspirate. Also, we want to consider DVTs and as well as hydrocephalus, fluid on the brain causing increased intracranial pressure. Now, the patient's outward appearance is not a good indicator of how well the patient will ultimately function in the home or work environment. So don't be fooled by that outward appearance. They can look fairly normal on the outside, but we don't know sometimes the extent of damage done to brain tissue. So the outward appearance, physical appearance, does not necessarily reflect what is happening in the brain. So hopefully through a series of tests, diagnostic testings, and psychological testings and such as that, will probably give us an idea of what is going on with this patient. Now, seizure disorders may occur in patients with non-penetrating head injury. Seizures may develop during the first week after the head injury, so be alert for that. Some patients may not develop a seizure disorder until years after the initial injury. These patients may be placed on anti-seizure drugs, may be used prophylactically to manage post-traumatic seizure activity, but this practice is somewhat controversial, as I think we may have discussed this earlier. Now, the mental and emotional sequelae of brain trauma are often the most incapacitating problems for these patients. When we talk about mental and emotional sequelae, those problems that follow mental and emotional issues with patients with brain trauma, again, they could be most incapacitating problems. One of the consequences of a TBI is that the person may not realize that a brain injury has occurred. Many of the patients with the head injuries who have been comatose for more than 6 hours undergo some personality change. They may suffer loss of concentration and memory and defective memory processing as well. Personal drive may also decrease with these patients. Apathy may increase. Euphoria and mood swings, along with a seeming lack of awareness of the seriousness of the injury, may occur as well. The patient's behavior may indicate a loss of social restraint, judgment, tact, as well as emotional control. Now, progressive recovery may continue for many years with these types of patients. Specific nursing management in the post-traumatic phase depends on specific residual deficits. Being able to return to work and maintaining employment is one of the challenges during the recovery period. These patients should be referred to a social worker. In all cases, the family must be given special consideration. They need to understand what is happening and be taught appropriate interaction patterns, provide guidance and referrals for financial aid, child care, and other personal needs. Assist the family also in involving the patient in family activities whenever possible. Help the patient and the family remain as hopeful as practical. The family often has unrealistic expectations of the patient as the coma begins to recede or minimize. The family expects a full return to pre-trauma status usually. However, in reality, the patient usually experiences a reduced awareness and ability to interpret environmental stimuli. Prepare the family for the patient's emergence from the coma and explain that the process of awakening often takes several weeks. In addition, arrange for social work and also chaplain consultation for the family as well. Now, when it is time for discharge planning, the patient, the caregiver, family may benefit from specific post-hospitalization instructions to avoid family patient friction. So you want to anticipate these problems as soon as possible. There are special no policies that may be appropriately suggested by the neurosurgeon, the neuropsychologist, and the nurse should include no drinking of alcoholic beverages, no driving, no use of firearms, no working with hazardous implements and machinery, things that can cause an injury to the patient, no unsupervised smoking. Family members, particularly spouses, go through a role transition as the role changes from that of spouse to that of a caregiver and probably sole financial maker in the family. So this can really be a very difficult period for these patients, to say the least, and but very frustrating as well. Now, the expected outcomes are that the patient with a head injury will maintain normal cerebral perfusion pressure, achieve a maximum cognitive, motor, and sensory function, and also experience no infection or hyperthermia as well. And now we turn our attention to inflammatory brain disorders. These conditions can also lead to increased intracranial pressure, so they are apropos for our discussion. Inflammation can be caused by bacteria, viruses, fungi, and chemicals. For example, contrast media used in diagnostic tests, blood in the subarachnoid space. Central nervous system infections may occur via the bloodstream, by extension from a primary site or along cranial and spinal nerves. So like blood cultures, septicemia can lead to CNS infections. Now, the mortality rate for inflammatory conditions of the brain is pretty high, between 10 and 30% in the general population, with higher rates in older patients. Up to about 19% of those who recover can have long-term neurologic deficits, including hearing loss. Now, older adults and persons who are debilitated are more often affected than in the general population. College students living in dormitories and individuals living in institutions, prisoners have a high risk for contracting meningitis. Um, Untreated bacterial meningitis has a mortality rate of nearly 100%. That's pretty significant. And must be reported to the Center for Disease Control, or CDC. Right. And as you can see here, acute inflammation of the meningeal tissue, well, bacterial meningitis is acute inflammation of meningeal tissue surrounding the brain and spinal cord. And usually you will see this condition in the fall, winter, or early spring, and often secondary to viral respiratory disease. So it starts off as a upper respiratory condition that can progress to bacterial meningitis. Now, these are some of the clinical manifestations of bacterial meningitis. Key signs of meningitis: fever, severe headache, nausea, vomiting, and what we call nuchal rigidity. This is when we tell the patient to touch, to take their chin and bend their neck, touching their chest. And if they have a neck pain, that is considered nuchal rigidity, or further assessment would be warranted. Coma associated with poor prognosis occurs in 5 to 10% of cases as well. Now, other symptoms that may be present: photophobia, meaning sensitivity to light. The patient may have a decreased level of consciousness, which is an early sign as well. Signs of increased intracranial pressure. Seizures, meaning seizures occurs in 1/3 of all cases. Headache that worsens, and vomiting and irritability may occur as well. If the infecting organism is a meningococcus, a skin rash is common, as well as petechiae. Petechiae are small pinpoint round spots that appear on the skin as a result of bleeding. And it may be seen on the trunk, lower extremities, and mucous membranes. A tumbler test can be done by pressing the base of a drinking glass against the rash. The rash does not blanch or fade under the pressure. So that's just a way to determine um, if the patient has petechiae, or if this rash is related to meningitis. Again, increased intracranial pressure actually causes one of the major causes, rather, of altered mental status. Um, One of the very early signs. Residual neurologic dysfunction may also occur. Cranial nerves 3, 4, 6, 7, 8 can be dysfunctional. And there's a sequelae, the sequelae varies by cranial nerves, or what will follow, if you will. The most common acute complication of acute bacterial meningitis is increased intracranial pressure. Most patients have increased intracranial pressure, and it is the major cause of the altered mental status as well. And of course, dysfunction often occurs involving many of the cranial nerves that I also just mentioned. Now, as far as some of the complications from bacterial meningitis, the optic nerve may be affected, which is cranial nerve 2, compressed by the increased intracranial pressure. This can also lead to papillary edema with possible blindness. There can also be ocular movements or ocular movements affected with irritation to cranial nerves 3, 4, and 6. These patients may develop ptosis or drooping of the eyelid, unequal pupils. Many don't confuse this with anisocoris, and also diplopia, or double vision. Now, papillary edema is the swelling of the optic nerve as it enters the back of the eye due to raised intracranial pressure. And here, again, this is why we have to get this under control. Now, the extraocular muscle nerves 3, 4, and 6 become irritated, and there may be movement issues as well. Cranial nerve 5 irritation, there'll be a sensory loss and loss of corneal reflex. Inflammation of cranial nerve 7. There's facial paresis or weakness. There's also irritation of cranial nerve 8. These patients develop tinnitus, vertigo, deafness. There's also hearing loss, or hearing loss can be permanent as well with this condition. The dysfunction usually disappears within a few weeks. But again, the hearing loss can be permanent after bacterial meningitis, unfortunately, for these patients. Now, hemiparesis, which is paralysis of one side of the body, dysphagia, hemianopsia, which is the loss of half the visual field, may also occur with these patients. These signs usually resolve over time. They do not, if they do not, a cerebral abscess or subdural empyema or pus forming, a subdural effusion, or persistent meningitis might be suspected, and further investigation is warranted. Um, let's see. All right. Now, acute cerebral edema may occur as an acute complication of bacterial meningitis. These patients may develop seizures, cranial 3 palsy, a bradycardia, a hypertensive coma, as well as death ultimately. Now, headaches may occur for months after the diagnosis of meningitis until the irritation and inflammation have completely resolved. It is important to implement pain management for chronic headaches. A non-communicating hydrocephalus may occur if the exudate causes adhesions that prevent the normal flow of CSF from the ventricles. CSF reabsorption by the arachnoid villi may also be obstructed by the exudate because it's so thick. In this situation, surgical implantation of a shunt is the only treatment here. There's a syndrome called Waterhouse Friedrichsen which is a complication of meningococcal meningitis. The syndrome is manifested by petechiae, DIC, or disseminated intravascular coagulation, adrenal hemorrhage, and circulatory collapse. Now, DIC and shock, which are some of the most serious complications of meningitis, are associated with meningococcemia. All right. Um, this is a rare infectious disease characterized by upper respiratory tract infection, fever, rash, skin rash, and lesions, eye and ear problems, and possibly a sudden state of extreme physical depression or shock. Now, when a patient has manifestations suggestive of bacterial meningitis, a blood culture and CT scan should be done. Diagnosis is usually verified by doing a lumbar puncture or LP with analysis of the CSF. A lumbar puncture should be completed only after the CT scan has ruled out an obstruction in the foramen magnum in order to prevent a fluid shift resulting in a brain herniation. Specimens of the CSF, sputum, and also nasopharyngeal secretions are taken for culture before the start of antibiotic therapy in order to identify the causative organism, and so it can be treated appropriately. A gram stain is also done to detect bacteria as well. Now, the predominant white blood cell type in CSF during bacterial meningitis is neutrophils. X-rays of the skull may demonstrate infected sinuses, which can lead to meningitis as well. CT scans and MRI may be normal in uncomplicated meningitis. In other cases, CT scans may reveal evidence of increased intracranial pressure or hydrocephalus as well. Now, prevention of respiratory tract infection through vaccination programs for example, pneumococcal pneumonia and influenza is also of vital importance. Meningococcal vaccines are available that protect against all sero groups of meningococcal disease that are most commonly seen in the United States, but they will not prevent all cases. There are three kinds of meningococcal vaccines available in the United States, and I'll let you guys take a look at the list that I provided for you. Now, as far as health promotion is concerned, um, we have to encourage these patients to take their seasonal pneumococcal and influenza immunizations. Of course, the meningococcal vaccines are available as well. Um, Keep in mind that early vigorous treatment of respiratory tract and ear infections are very important in order to prevent bacterial meningitis. And also prophylactic antibiotics for anyone exposed to bacterial meningitis is also warranted as well, especially those who are living in pretty close quarters. Now, the most common causes of viral meningitis, we just discussed bacterial. Now we turn our attention to viral meningitis. Most common causes are enterovirus, the arbovirus, HIV, as well as herpes simplex virus. Most often spread through direct contact with respiratory secretions. Usually presents as headache, fever, photophobia, as well as stiff neck or nuchal rigidity. And fever may be moderate or high. There are usually no symptoms of brain involvement with viral meningitis. Now, the expert EV test is used to rapidly diagnose viral meningitis. A sample of CSF is used to determine if enterovirus is present, and results are available within hours of symptom onset. The CSF can be clear or cloudy, and the typical finding is lymphocytosis. Organisms are not seen on gram stain or acid fast smears with viral meningitis. Um, Now, there's a test called a polymerase chain reaction, or PCR, is used to detect viral specific DNA and RNA. Um, it is a highly sensitive method for diagnosing CNS viral infections. So you may hear about these types of tests as well. Now, antibiotics are the best defense for bacterial meningitis and can be easily discontinued if the meningitis is found to be viral. Viral meningitis is managed symptomatically because the disease itself, like any viral infection, is self-limiting. Full recovery from viral meningitis can be expected. Um, Rare sequelae include persistent headaches, mild mental impairment, and incoordination. Um, Pretty much full recovery is expected with viral meningitis. So now let's take a look at encephalitis. In the U.S., encephalitis is responsible for about 20,000 cases and about 1,400 deaths annually. Ticks, mosquitoes transmit certain epidemic encephalitis, such as the Eastern equine encephalitis, the lacrosse encephalitis, St. Louis encephalitis, West Nile encephalitis, and Western equine encephalitis. Non-epidemic encephalitis may occur as a complication of measles, chickenpox, as well as mumps. Herpes simplex encephalitis is the most common cause of acute non-epidemic viral encephalitis. Um, Now, the acute inflammation, there's acute inflammation of the brain. It can be serious, sometimes leading to death. Um, there's also CMV encephalitis, which you would normally see. This is a cytomegalovirus that is commonly seen with AIDS patients as well. Now, virtually any CNS abnormality can occur, um, including hemopharesis, tremors, seizures, cranial nerve palsies, personality changes, memory impairment, amnesia, as well as dysphagia. The onset is nonspecific. The patients may develop a fever, a headache, as well as nausea and vomiting. The signs appear in about 2 to 3 days. It may vary from minimum alterations in mental status all the way to coma. Any CNS abnormality, um, of course, it can be very serious. Now, early diagnosis and treatment are essential for favorable outcomes. And so just take a look at these different tests that are performed, CT, MRI, PET, the PCR test for herpes simplex DNA, RNA, blood test for West Nile viral RNA, and also the Zika virus as well. Now, diagnostic findings related to viral encephalitis are shown in table 56-16. So go ahead and take a look at that. Now, West Nile virus should be strongly considered in adults older than 50 years of age who develop encephalitis or meningitis in the summer or early fall. The best diagnostic tests, of course, for the West Nile virus will be it is a blood test that detects viral RNA. Now, this test is also used in screening blood, organs, cells, and tissues that have been donated as well. Mosquito control or prevention of encephalitis, it requires mosquito control. You see them going around spraying in the summer, especially rainy seasons. And this also includes cleaning rain gutters, removing old tires, draining bird baths, removing water where mosquitoes can breed. In addition, insect repellent should be used during mosquito season. Interprofessional and nursing management of encephalitis, including West Nile virus infection, is symptomatic and supportive. In the initial stages of encephalitis, many patients require intensive care level or intensive care level of care. Now, acyclovir and also vidarabine are used to treat encephalitis caused by herpes simplex infection. Acyclovir has fewer side effects than vidarabine and is often the preferred treatment. Use of these antiviral agents has been shown to reduce mortality rates, although neurologic complications may not be necessarily reduced. For maximum benefit, antiviral agents should be started before the onset of a coma. Treat seizure disorders with anti-seizure drugs. Prophylactic treatment with anti-seizure drugs may be used in severe cases of encephalitis. Again, these drugs have been, they can be effective in reducing the mortality rate. Let's see. Folks, I think that's about it. That's all slides have been discussed. So I will go ahead and get this posted for you all to take a listen to, packed with a lot of information. And so I'm very glad I was finally able to get through this. And so this will make life a little easier for me and for you, actually. Anyway, I do again thank you for listening, and hopefully you will find this voiceover to be useful in educating you on inflammatory brain disorders as well as head and brain trauma. Thanks all.